motivated to go. So deep dive I did. And then I was reintroduced to a past president of FIGO, who in 2002 said, women are not dying of untreatable diseases. They are dying because societies have yet to make the decision that their lives are worth saving. We have not valued women's lives highly enough. Okay, for real? I went from shaken to shattered. How much more, I asked, how much more? Are we really making any advances at all? The crazy just keep coming. Okay, so next step, keep on reading, keep on trying. And then I ran headlong into PPH. Yes, that PPH that can kill in the first few minutes. WHO now strongly recommends early use of IV tranexamic acid within 3 hours of birth as standard care for women with PPH, whether it be genital tract or uterine acne. So how did the reality of PPH bring me from a moment of despair? Well, it started with a Japanese woman in the 1950s. PPH then was a leading cause of death in Japan, and Utako set out to identify a drug that would reduce mothers dying. Resources were hard to find, a male-dominated medical field, and after giving birth, she even brought her baby to the lab. She knew that there was a way, she just needed to figure it out. And in 1962, published about this drug, tranexamic acid, TXA, which was 27 times more powerful than anything known. But the local obstetricians were not interested, and TXA was eventually marketed to stop bleeding for tooth extractions. Years later, research finally recognized what tranexamic acid could do for trauma patients. And in 2010, there was a crash trial for over 10,000 patients published in The Lancet. It reduced trauma patients' bleeding. This then went on to the woman trial, which specifically focused on pregnant women and found that the TXA significantly reduced PPH death. Utako passed away shortly after recruiting for that woman study with 20,000 global participants in April 2016, almost 50 years later. But she said she wasn't worried about the trial. She knew the results. I know it's going to be effective. If you have time, I encourage you to dig a little bit more into the story of this drug, to hear the contrasting cases of Pakistan and Nigeria. As my children would say, I went right down the rabbit hole. It was delving into these two countries with high maternal mortality that actually gave me the oomph to go on. In one country, the drug succeeded and in one failed. What was the key to success? Local champions, an unbroken chain from people to organization. Local champions who fought the cause, political support, national guidelines, association and membership, training, the request, availability locally, providers who saw the value and provision free of charge. Well, then it all clicked together. This is exactly what we are being called to do as midwives today, to don't give up, to keep on going, to take the long view, adapt, be flexible, to push through insurmountable barriers. And so we push on, and we will push further and faster, even with the campaign that was launched at the end of this year's International Confederation of Midwives Congress. PUSH is a decade-long global women and midwives to protect and uphold bodily rights and autonomy. PUSH will accelerate progress in reducing maternal and neonatal mortality and advance sexual reproductive health and rights, addressing key barriers in leadership and shift some of those underlying gender norms. The PUSH calls upon us as member associations and individual midwives to push, to engage traditional and non-traditional donors, to push targeted policy and advocacy, to push global communications campaigns. When you go through the suggested activities, you'll see the PUSH campaign calls us all to reach into our activist midwife selves, putting women out front, putting ourselves out there in an entirely different way. making our stories known. Carrying the inspiration from a Japanese woman ahead of her time and a drug that went from skin lightening to tummy tightening that saves thousands of lives, easily administered by midwives. So here I am today with you again, shaken but not shattered, proud of the diversity of midwifery in the Caribbean, proud of the indomitable spirit that has carried us from the nanas of colonial times to a professional cadre. We dig deep to push, and we stay focused on doing what's right and what we know works. Even as the world continues to spin wildly, we are not chained by the past or by these current challenges. We rise forward to a future that we shall determine, learning from what worked and what didn't. We push today for what we want tomorrow. Push it, according to several sources related to labor, remains one of the top labor songs for Second Stage, ironically released on International Day of the Women. We as midwives of the Caribbean will push it, push for change. We will push it real good. Thank you.
Thank you very much, Pandora, for those words. And we know we encourage our midwives to keep pushing. Keep pushing. We can't give up. Thanks ever so much for those open remarks, Pandora. Next, we go to Dr. Sandra Lan to bring us opening remarks. Dr. Lan is the UNFPA representative. So we welcome Sandra.
Thank you, Marcia, and good evening, everyone. It's great to be with you all, even if it isn't in person. This virtual format provides us an opportunity for more people to attend. I don't think other meetings that I've attended have had quite so many. But at the same time, we all miss the chance to network face-to-face between sessions and after closing each day. And there's less time overall for updates and to share experiences with each other. I have fond memories of the CRMA meeting in Barbados in 2019, when we were still able to travel for events. And I see a number of familiar faces, the ones that are on the screen, and many familiar names on the list of participants. I bring greetings and best wishes for a successful meeting from Vicky Camacho from the UNFPA regional office in Panama, and Pilar de la Corte from the regional office in Jamaica. August is a time of year for vacations, so our UNFPA staff can enjoy some downtime with their family and friends. They were sorry not to be with you, but are looking forward to the results of the meeting. They asked me to reiterate UNFPA's commitment to support CRMA and midwifery in the Caribbean, and to express our satisfaction in the development of CRMA as it has continued to gain recognition and provide leadership in the region. The work undertaken to support midwives with educational programs and other resources during the COVID pandemic, as well as the ongoing efforts on respectful maternity care, deserve particular mention. As the United Nations Sexual and Reproductive Health Agency, the UNFPA mission continues to be to deliver a world where every pregnancy is wanted, every childbirth is safe, and every young person's potential is fulfilled. Since 2018, efforts have focused on the achievement of 3 transformative results. Number 1, ending unmet need for family planning. 2, ending preventable maternal deaths. And 3, ending gender-based violence and unsafe practices. UNFPA continues its commitment to strengthening midwifery because midwifery development is an effective strategy to achieve those transformative results, to increase the quality and availability of sexual and reproductive health services, and because midwives
Niall,
live.
what are you doing? Huh?
The technical
One second.
Lenta.
Sorry about that, Sandra.
No, that's fine. The technical support provided by Deborah Lewis as a UNFPA midwifery consultant for the Caribbean and the CRMA UNFPA annual work plan are concrete measures of that commitment. So congratulations to all of you on another year of solid work and progress in spite of the challenges presented by the COVID-19 pandemic. And finally, best wishes for a successful annual general meeting. Thank you.
Thank you very much, Sandra, for bringing us those opening remarks. And we always acknowledge and thank UNFPA for their continued support to CRMA from the inception. We have been partnering with UNFPA from the beginning, and we thank you ever so much for continuing to support CRMA in all of our endeavors. Thank you. Next on the program, we want to honor our midwives who have left us, who have passed on from our last AGM to now. So we want to move to our honoring our midwives. So we want to have a moment of silence while we acknowledge those midwives who have passed on. If in looking at the names, you don't see a midwife from your country who has passed on and her name is not here, please put it in the chat so that we would be able to acknowledge her. So we pause for a moment of silence. Thank you, ladies, for acknowledging all the midwives who have left us and passed on. I haven't seen any additions in the chat, but as we go along, if you do remember anyone, put it in the chat and we will acknowledge them. Thank you very much. This then brings us to the end of our session 1. And so, like the good midwives that we are, we've been sitting now for just about half an hour, just over an hour. So we need to get up and do some stretches. So we will now have our stretch break before we enter into session 2. And this session would be moderated by Mrs. Sonia Watson from Barbados. Watson Miller from Barbados. So could I encourage you to stand and take a little stretch so that we, keep the circulation going. We don't want to have any DBTs as we continue with our AGM. So stretch, feel free, as tall as a building, as they say, as wide as a house. So great. We have a stretch break, get some water and come back. We are going to continue straight into our next session. And I give you over to Mrs. Sonia Watson Miller. Sonia.
Hello. Well, good night, good evening, or good morning, wherever you are. Hello and welcome. My name is Sonia Watson Miller. I from Barbados, a registered midwife. And this session too, we're going to be looking at the State of the World Midwifery Report for 2021. We have some wonderful presenters that will be presenting the report to us. And I will also read the bio. After the report, we have questions and answers. So if you have any burning question and you are like me that might just forget, there's a chat, write it in. Can't forget when it's there. We'll be able to see. So hold your questions after the presentation at the end. One of our presenters will be Sandra Land. Dr. Sandra Land is a consultant of UNFPA. Since retiring from PAHO in 2005, Sandra has worked as a part-time consultant, initially for PAHO and then UNFPA, beginning in 2011, supporting midwifery development in Latin America and the Caribbean. She was the regional advisor on local health services for PAHO in Washington, D.C. during the period of 1990 to 2005, which included nursing and midwifery services in Latin America and the Caribbean. So she has had the opportunity to visit most of the Caribbean countries and has worked with many of your early nursing and midwifery leaders. Before joining PAHO, she provided and managed public health nursing services and maternal and child health programs in Texas, Delaware, South Carolina, Pennsylvania, and the rural Guatemala as a Peace Corps volunteer. Sandra is not a midwife. Her background is in nursing, maternal and child health, women's health, public health, and international health. In my opinion, when you do that general nursing, you got some experience in obstetrics, we will bring you in if we need you. Although retired, she is staying involved in Latin America and the Caribbean to prepare and mentor new group of midwifery consultants and leaders like Deborah, Shirley, and Marcia. Sandra's day job is taking care of her 8-year-old grandson, Calvin, near her home in South Carolina, USA. So you see, a little bit of midwifery experience there, got a grandson. So Sandra will be one of our presenters. Our next presenter will be Dr. Pandora Hartman, which you heard earlier. She serves as the Chief Nursing and Midwifery Officer of the Johns Hopkins Program for International Education in Gynecology and Obstetrics, which is a large international nonprofit health organization. She has gained 20 plus years of nurse midwifery experience working in the USA, Caribbean, Southeast Asia, the Middle East, and Africa in varying capacity, delivering babies and assisting women and families on 4 continents. When not traveling and in the US, she continues to serve in the social, economically, and culturally diverse practices in the Atlanta metro area. As she continues to mix global health administrative, advocacy, and clinical duties, she is known for encouraging nurse midwives to push for change past the perineum. And we are going to be pushing along with her. So we welcome Pandora. Our next presenter will be Devi Stewart, who is a passionate midwife who strives to support women in the childbearing age through the pregnancy journey. She is an advocate for normativity in midwifery practice and empowerment. She has presented in conferences, both locally and internationally, addressing the use of simulation in midwifery practice and maternal mental health. Mental health is becoming a very important thing since we have COVID, so that experience will be quite good. Devon has allowed her to contribute to the continued development of midwifery practice in Jamaica. She actively contributes to both nursing and midwifery through her participation in the Nursing Council of Jamaica, where she sits on the Curriculum Verification and Practice Committee. Deborah, I hope I'm getting your name right. You can always correct me. Education qualification includes a Master's of Science in Midwifery Education, a Master's in Public Health, a postgraduate certificate in midwifery supervision, and a postgraduate certificate in higher education, and she's a registered nurse. She is currently pursuing her PhD in career and technical education at the University of Technology in Jamaica. Her research interests are in the areas of normal midwifery practices, midwifery education, and sexual health. In her community involvement includes being a member of Women's Health Network, as well as serving on the board of E for Life, a registered charity that supports abused women and children and those living with HIV and AIDS. Our next presenter, I'm just reading the bio for the presenter, so just bear with me, is Bobby Jo Campbell. Bobby Jo is a practicing registered midwife for over 15 years with work experience in both primary and secondary healthcare. She currently works with St. Mary's Health Department as a midwife supervisor and has been an active member of the Parish Infant and Young Child Feeding Committee since 2015. She is a trained young midwifery leader since 2018. Bobby Jo serves as the Vice President of the Caribbean Regional Midwives Association. At the national level, she represents midwives as President of the Jamaica Midwives Association. She is a member of the committee at the Ministry of Health and Wellness Chief Nurse Office that is actively working on the strategic direction for nursing and midwifery in Jamaica. Bobby Jo is deeply passionate about her profession and has dedicated her service to midwifery at every possible presenting opportunity. When she is not conducting midwifery-related duties, Bobby Jo serves as a captain in the Jamaica Combined Cadet Force. One of her favorite quotes is from John Quincy Adams. If your actions inspire others to dream more, learn more, do more, and become more, you are a leader. And we can take that quote too as well. If your actions inspire others to dream more, learn more, do more, and become more, you are a leader of midwives. And finally, our next presenter will be Betty Ann Pilgrim, who completed her training as a registered nurse at the San Fernando General Hospital in the late 1980s. She then migrated to the United Kingdom, where she spent the next 20 years. While in the United Kingdom, she pursued midwifery, family planning, and has a Master's of Science degree in social anthropology of children and child development. Mrs. Pilgrim returned home in 2008 in order to give back service to her country of Trinidad and Tobago. She has held several posts like lecturer, clinical instructor at the University of Southern Caribbean, excuse me, matron of area hospital point 14, then San Fernando General Hospital, where she received one of SWRHA Quality Awards for her innovation and unique leadership style, and was selected for a major International Scholarship Award by the Global Nursing Leadership Institute of Geneva in Switzerland. Betty Ann has distinguished herself as an accomplished daughter of the soil and a national leader of good repute. She is currently serving as the Chief Nursing Officer or National Administrator of Nursing Services for the Republic of Trinidad and Tobago, as well as board member of the Nursing Council of Trinidad and Tobago. She is married to the economist, Dr. Stephen Pilgrim, who is a professor at Montemorelos University in Mexico, and they have one teenage son who attends the Great Atlanta Adventist Academy, SDA, in Georgia. Betty Ann is an avid reader and a strong contributor to events of Women Family Life Ministries. We welcome our presenters. The question and answer segment will be done by Mrs. Deborah Lewis, UNFPA representative. Ladies and gents, because we know there are some midwives that are men, listen now as our presenters present the State of the World Midwifery Report.
We're going to start with Sandra.
Okay, could I have the slides, Deborah? So hello again. We thank CRMA for including this topic on the agenda of your annual general meeting. If you have had a chance to look at the SOMI 2021 publication, you'll recognize the image from the next slide, Deborah. The 2021 edition presents findings on the sexual, reproductive, maternal, neonatal, and adolescent health. SRMNAH is the new acronym that I have a lot of trouble with. Workforce of 194 countries. The report, prepared by UNFPA, ICM, WHO, and Novometrics, identifies barriers and challenges to future advancement. It shows a global shortage of 1.1 million sexual reproductive health workers, including 900,000 midwives. The two acronyms you're going to see on the slides, SOMI for the State of the World's Midwifery Report, and SRMNAH, which stands for Sexual, Reproductive, Maternal, Neonatal, and Adolescent Health. And I'm going to be referring to that last one as Sexual and Reproductive Health, since I can't seem to say the acronym very efficiently. Next slide. SOMI was launched globally on May 18, 2021. Some of you were able to attend, I know. The agenda for the launch included remarks from the Minister of Health from Jamaica. SOMI 2021 provides an updated, evidence-based, and detailed analysis of the present progress and future challenges to deliver effective coverage and quality of midwifery services. It outlines progress made since SOMI 2011 and SOMI 2014 in relation to the midwifery workforce, midwifery service coverage and quality, as well as the education, regulation, and professional status of midwives. Guyana and Haiti are the only Caribbean countries with profiles in these prior reports. Next slide. All UN member countries have an online profile available now in English, Spanish, and French. However, the profile does not present an accurate picture of midwifery in many countries because the National Health Workforce Accounts, NHWA, is the source of much of the data, and those data are incomplete. Also, many countries did not complete the ICM surveys on education, regulation, and leadership. If we were in a room together right now, I would be asking how many of you knew of the survey, the ICM survey, and helped to complete it. Sometimes validation letters from the competent authorities, education, regulation, and leadership were not submitted in time. So the ICM survey data could not be used in the SOMI 2021. Next slide. So what about your countries? 5 Caribbean countries with ICM members completed the ICM. Guyana, Haiti, Jamaica, Suriname, Trinidad, and Tobago. Validation letters were submitted except for Suriname. The Bahamas, as a member of CRMA, submitted the ICM survey, but not the validation letters. Therefore, for the ICM survey data from only 4 countries were used for the regional, that's the Americas analysis, and for the country profiles. But perhaps the biggest gap for the Caribbean is that most countries did not report a number for nurses with midwifery training or nurse midwives. separate from nurses, resulting in an undercount of the number of midwives. So when you look at the country reports, you'll see 79 midwives in Guyana, 197 in Haiti, 398 for Jamaica, and 236 for Trinidad and Tobago. These were the 4 countries with validated ICM survey data, and some midwives reported on National Health Workforce accounts. I think most of us will know that there are more midwives in those countries. These factors explain much of the missing data. When you look at the country profile, you'll see a lot of NDs because the data are missing. However, these limitations do not necessarily preclude using SOMI as a tool for advocacy until your better data become available. Next slide. This slide, which you probably can't see very well, presents the results of the analysis on the second page of the country profile. The first column presents the potential to meet the need with the current workforce and in 2030. So the first country, Antigua and Barbuda, they are currently, according to the data, could meet 100% of the need and are projected to meet 100% in 2030. So we should note that a number of the countries show 100% for both, although several others show deficits now and projected deficits in 2030. I'm showing these because I want to encourage everyone to take a look at their country profile. The second column shows the capacity of the health system to employ the available workforce in 2030, or what is referred to as demand. There's interesting variation here across countries from severely below, where there are projected shortages, so the country could employ more if they had more, to exceeds for some of the countries showing 100% of need met. So those countries are, according to this analysis, are perhaps producing more personnel, more healthcare workers than the country could employ. The document, How to Read Your Country Profile, explains all of this in great detail. And we will talk, we'll show you where you can find that document as well in a bit. The next slide, please. Information is essential for implementation of the 6 elements of the UNFPA program strategy, midwifery program strategy, which we launched during the CRMA meeting in Barbados in 2019. Shirley mentioned that in her remarks. So even though there will not be a 4th SOMI report, UNFPA LACRO is committed to the goal of having better data available for planning, monitoring, and evaluation of the support we continue to provide to strengthen midwifery here in the Caribbean and across the region. Data become more and more important as resources become more scarce, because we like to be able to show that we are making a difference. Next slide. A new study by Nove and others, including several who were on the writing team for SOMI 2021, was published in January. It used modeling and revealed that investing in professional midwives could save millions of lives. Achieving universal coverage of interventions provided by midwives by 2035, the model estimated could prevent 67% of maternal deaths, 64% of neonatal deaths, and 65% of stillbirths. The model used information from 88 countries, and they were the countries with the most maternal and neonatal deaths and stillbirths around the world. This analysis indicates that integrated, licensed, fully prepared midwives, supported by interdisciplinary teams, can perform approximately 90% of the sexual and reproductive health essential interventions throughout the life cycle. However, midwives currently represent less than 10% of that global workforce. Next slide. SOMI 2021 concludes that urgent investment is needed in education and training, in management, in regulation, and work environment, leadership and governance, and also service delivery. So for midwives to achieve their full potential to save lives, these bold investments are needed from governments, regulatory authorities, educational institutions, professional associations, international organizations, civil society organizations, and researchers at the national, regional, and global levels. A lot of organizations that we are hoping that SOMI will be used for advocacy to generate investment for midwifery. We at UNFPA invite all of you to look at the recommendations on pages 60 to 61 of the report. Look at the profile for your country. Even countries with pretty good data have gaps. However, as I said before, poor data in the report doesn't necessarily mean that the recommendations aren't relevant for your country. You can use SOMI for advocacy while at the same time compiling the data you need for making a stronger case for more investment in your country and the Caribbean subregion. The next slide. Which brings me to this slide, the research agenda, which you'll find on page 62 of the text. Midwives want strong midwifery research, followed by implementation of the evidence. Some of the priorities of research you see here, they include countries with more than one pathway. The question is to study competencies, if the competencies vary, and are the midwives that come out of those different pathways deployed differently. A lot of work needs to be done on identifying better ways of meeting the needs of adolescents, because adolescent pregnancy continues to be an issue for many countries. We need analysis of subnational workforce data. Unfortunately, the SOMI, well, not unfortunately, because of the way it was developed, the SOMI looked at national data. It didn't look at subnational. So some of those data about met need and demand are suggesting that 100% of the need could be met, but in many places, the personnel aren't evenly distributed across geographically. They're suggesting to look at reasons for variations in scopes of practice across countries. It varies from country to country what midwives are permitted to do in the areas of family planning, as well as prenatal and delivery services. And finally, evaluating approaches that were used in response to COVID-19. We challenge the researchers that are listening to consider these priorities. This research, we know, can contribute to the knowledge about midwifery in the region and provide a better understanding for the world at large. And this next slide and the last slide, this slide provides the links to the SOMI text and related resources, including the document and how to read your country profile. Deborah and I will be available to support work you want to do in order to have better data in the future. So now I'm going to turn the presentation over to Deborah, who will decide, I don't know if we have time now to do it, Deborah, but we want to be sure to show you how to find SOMI, including how to locate your country profile. And thank you again for having us this evening.
Thank you, Sandra. I'm just going to change the screen and new share. Please tell me when you can see.
I'm seeing it.
You're seeing it. Okay. So we just wanted to show you how to access the report. So I'll put the link in the chat. You can see up here what the link is, but I'll put it in the chat so you can access it. And when you go to the page, this is what you see. that Sandra showed you. And as you scroll down, you will see the other things that she mentioned. So you will see the entire publication, you'll see the executive summary, fast facts, and the annexes. But what we wanted to show you is the map, because, you know, we're here, but you can't see us, right? We're like almost little invisible dots. And that's because if you look here, you see the lightest dot is not reported. So we really barely appear. However, if you hover over, like for example, if I click here, you can see some things here. So we see that that's Guyana. And if you go somewhere further up here, you see Dominican Republic. So they're right here in the chain. There are some countries that you might find. However, the easier way to find it is to go to this, and then you get a drop down. And then it's much easier. So you can click on Barbados. You'll see Barbados comes up, you click on it, you'll see the information comes up. And then if you click at the bottom here for the country profile in a PDF format is where you really get the bulk of the information. Unfortunately, as Sandra mentioned, for many of them, you will see NR, which is not reported, or ND, no data, for many of the islands. Anyway, but we just wanted to show you as so that you have a sense of how to find the information, right? So drop down, Trinidad and Tobago, we go here, we click on the country, this basic information comes up, click on this, and then you get the full profile, PDF profile. So that's it. Thank
Deborah,
you.
Deborah,
Yes.
go down, back to the map and go down to the very end of the map and show them where the document on how to read or how to use your profile.
Right. Okay. So there's this document here with how to read the country profile that gives you how to use the country profile. So it gives you step by step of how to interpret the data that appears on the PDF.
Thank you.
Right, so that's really on this same page. So the home page, when you go there, all of the information is on this page and will take you to somewhere else. The map is here, and then that button here, how to read the country profiles. All right, so thank you. I'll stop sharing now and we can go on to the next presenter.
Thanks very much, Sandra. Our next presenter is Dr. Pandora Hartman. The floor is yours.
Good evening, everyone. I am just pulling up my slides. Great. I'm going to take a few quick moments to carry this a little bit further. As the International Confederation is an overarching agency who is looking at the strengthening of our professional midwifery associations. So the summary report was launched in the middle of our new strategic directions, which came out just this year. They are available on the ICM website, so I will put the link in and you can have a look at those. But I'm pulling this into strategic priority 3, fostering a movement for midwifery and strengthening partnerships advocacy. The State of the World's Midwifery tool is a strong and powerful advocacy tool to leverage, to influence and educate the policymakers, because we do know that it is the policy lack thereof, the changes thereof that are impacting the numbers of midwives that there are and our availability to actually practice. So what has happened with the summary report is right in line with our new strategic priorities as well. We see as well that the report also goes into carrying forward what we looked at as celebrate, demonstrate, unite, demonstrating that the body of evidence around midwives is that we make a difference so that we can implement actually the professional framework in every country. And we see here the interface of the professional environment, the economic and social development on what we're actually able to do as midwives. So the part of the underlying of the SOMI goals was to bring some of these other pieces together, to bring us as midwives associations the ability to raise the profile of women and midwives. So there's this report, how do we do this actually? How do we bring the SOMI to action? Now that you've seen a little bit of the underlying thinking, how do we do this? Well, we see here just the copies of the previous SOMI reports that are all accessible still as well. The SOMI reports actually interface with each other, the 2011, 2014, and now this SOMI report. They are meant to be kind of looked at as building blocks, because in some of the other reports, you can also see more information about the education system. I show you in the middle as well what some regions have done, and I've sat in on some of these in the Africa region where they are looking at doing their own subnational reports about what is needed in midwifery, so that we have a more in-depth look so that people can bring the messages home in a greater way. When we look at this year's SOMI report, the biggest message was investing in midwives, right? Investing in the health workforce, investing in quality education. And as ICM, it's our hope that we can help you invest in that way, particularly when we're looking at enabling environments and some of the parts that are perhaps less pulled out, pulling all of those to light. So because of that, and when we look at the goal, you have your association does continuing professional development. We need to push ourselves as midwives. So this is also why another data source was created in partnership with Direct Relief, the Global Midwives Hub. Many of you may be familiar with data visualization, because the world today is these large volumes of data that are coming at us. We don't have time to read this, right? Sometimes looking at another 100-page document is going to be a little bit too much. So we want to connect the people to understand the data so that they invest in midwives. You can access this through the Global Midwives Hub, and using storytelling and what data says to help us invest in midwives. We see here there's some future planning for connections, for webinars, for online training to get us up to data speed, data viz, complex data in graphical format. Why is this important? Because we're using the pictures, and you can see on the original UNFPA site and also on the Global Midwives Hub site that we are visually making the case. You can see this was a data graphic that was prepared for the 2014. So using this for the here and here, letting people look at patterns and images. You can, if you think back to the purple countries, we can see where the workforce densities, it's at a glance. So it's more digestible in the 3-minute elevator speech that we have these days. Here's another example of how the data viz, as we call it, is used. They're using this for healthcare, for patient-facing populations. And of course, I think with what's going on, everybody's gotten really kind of used to these maps and graphics, looking at them every day, the moving data. So we're also trying to capitalize upon what we know, how healthcare imagery and advocacy has changed to create this. There is a Visualizing Health project out of the Robert Wood Johnson Foundation that any midwife can also go into and do her own sort of a CPD to upskill herself on data visualization. So here in brief, we see how this mapping, using the data in the SOMI report and bringing it to life outside of the words, is going to help so that we can reflect our data, so that we can collect it in real time and update, so that when we are going to the policy making table or the educators, we have what is happening in real time. And this, because so many of us, were originally clinically focused, it's edging into new territory, and edging ourselves into new territory as one of the goals of what we want to bring to you as supporting midwifery associations. I know that was quick, rapid, and in a hurry, but this big data, this data visualization is an emerging field, and I look forward to chatting with you more about this. Over to the next.
Thank you so much, Pandora. And now our next presenter will be Devara Stewart.
Thank you so much, but it's Devry.
Devry, sorry. My apologies.
That's all right. You're forgiven. Deborah, my slides are ready, or did you want me to upload them?
No, sorry, I thought you said you would share them yourself.
Yeah, I would share them. Can I get
Okay.
privilege?
Oh, Shirley, can you make, right, okay,
Thank
thanks.
you.
Mhm.
All right. Good evening, everyone. And before I start, I'd like to go back a bit. Oops. From current slide, yes. And I'm too far ahead there. Right. Now, from the State of the World Midwifery Report, there are a few things I took out. And we look at it from the Caribbean's perspective, because what I did, I looked from the recommendations or the findings from the State of the World Midwifery Report, and I incorporated it and looked at it from a survey we did through UNFPA and matched it against it, which showed some real gaps. Now, I'll start by saying the aim of education is to look at the needs of our midwives in general, and then we make a conscious effort to make change. Things changes, and how do we as midwives adapt and change to meet these needs? Now, we look at what happens in the rest of the world, as my presenters before commented on, but in our region, what happens? How is our region so unique, and how can we meet the educational needs of our midwives to address midwifery education for us to be able to care for women, the newborn, and our adolescents? Now, we look at the key challenges from the State of the World Midwifery Report. Lack of investment in educators. Now, when was the last time in the Caribbean any of our governments would say, let's send midwives away, or let's pay for them to be educated? It would be an interesting discussion to find out. So we are not investing in education for midwives. And when I say education, you know, it's nice to have midwives who have a rich practice to be able to get them on a level, get them into midwifery education to support our profession and take it forward. So we need to look at that as a region, as it was pointing to all of us. And from the UNFPA report that was done in the survey that was done in the Caribbean, it showed a lack, and the respondents, the educators who responded, did say there was no investment for them to improve on what they already know, or if they saw changes, how can they adapt and make? It also found that there was limited knowledge and skills in contemporary teaching and learning. So we had from the UNFPA report, which was brought out in SOMI, there was a lack of capacity development, new ways of teaching to advance our profession. Why should we stay the same way? Why is it, as a region, some of us want to stay in the then and not going forward with now? You know, moving with digital technology, for example. How can we incorporate digital technology into midwifery training so as to enhance our profession? I'm sure it would be beneficial to what we do, and it would take some of the stress off us. Also, the SOMI report highlighted inadequate hands-on experience for students. The global standards are not being met, and there's a need for curriculum review and development. Now, how do we look at our hands-on experience for students? Is it that the curriculum is filled with all these courses that are university-based courses, and it's lacking in the midwifery skills? How often as a region, as a country, we really sit down and review our curriculum and match it against the global standards and aim to change it so that our region benefit, our women in the region benefit from quality maternity care, that our adolescent benefit, that our newborns benefit. How do we prepare our students to partake in research, hands-on research? How do we cushion them? How do we support them? And likewise, not only to do research, but to also publish their findings and also empower them to use these findings to make changes in practice. The report also found gaps in infrastructure, resources, and system. Now, most of our countries, we complain there's nothing to work with. There are no resources. There's nothing in place to support us. You know, how many of us, we are doing the courses and we do not have the facilities to engage our students online, to show them what is happening really, or even using something basic, what I call basic, as simulation to help guide them. What is there to help us? What is the state of our midwifery schools? When was the last time we had a good look at them and see how it impacts on their education? And how do we advocate to get resources within our education system as midwives? As I mentioned, simulation skills and equipment. Now, our role as midwifery educators, as some of my previous presenters, you know, they captured some of this. We need to capture the expanding role of the midwife. You know, it was mentioned earlier that we have different practices and the role we play, not different practices, but the different roles that we play in each country. We should come together as a team and look at the roles and see how it will benefit us so that we can look at our roles across the board and then, along with our member associations, move then to remuneration and recognition of these roles so that we can have educational courses to support these roles so that there is no hidden agenda seen, or there's nothing hidden to say that, oh, this person was promoted and they have nothing to show. So we need to look at it, come together, tighten up on that and move forward. We also need to develop educational pathways to develop these roles. Yes, I qualify as a midwife, but what then? Where do I go from here? You know, I mentioned this because recently we've had some graduates in Jamaica who are degree trained midwives, and they approach me, they go, Miss, now that I'm finished, what are my avenues? You know, they're interested in midwifery. They do not want to do nursing. They do not want to do social work. They do not want to do a law or anything like that. They want to advance in a next stage of midwifery. What educational pathways as educators can we develop to develop these roles of the midwife, to enhance them, right? In one country, I knew they had the midwife ultrasonographer. And I mentioned it to a friend of mine, you know, at work, a colleague really, and she said to me, well, you'll face a fight from the radiographers. Who best to do that job than the midwife? Because should there be not so good news, who best to cushion that woman? Who is best to break that news? Should she wait until she see the doctor? Or should the doctor come there supported by the midwife and then the midwife cushion this woman? So it is how we put it, how we are going to develop it, and how do we integrate it in 21st century midwifery. As educators, we need to support local midwifery associations to agitate and initiate for changes to local policies, right? I know we can as a strong body. As a strong body of midwives, I know we can, but our educators, need to support our associations, be a part of our associations, be a part of research within the associations, and agitate our governments so that local policies can be changed. Once we change our local policies, then we can tackle it from a regional point of view. That's without getting political. We can also foster leadership by encouraging professional development and providing support. As midwives who have been in the profession for a while, we need to support the development of our junior midwives so that we can pass the baton on. We identify the leadership roles in the midwife and push them for change in our profession, right? And one of the things I always support, I always say, sometimes it's not the years of experience that shows leadership, but it's the quality of the developing midwife that as sometimes as educators, it is seen in the classroom. It's how we go forward and support these persons to be leaders in our 21st century. And that brings me to the end of my presentation as I await the question time.
Thank you so much, Deborah.
Deborah.
Debbie, I'm going to get it right before the night is out.
That's all right.
Our next presenter was Mrs. Betty Ann Pilgrim, National Administrator of Nursing Services of Trinidad and Tobago. She's unable to be here right now, so Deborah Lewis from UNFPA representative, she will present on her behalf. Deborah?
Yes, please tell me when you can start seeing the slides.
Go ahead.
Okay. All right. As our facilitator said, she was unable to be with us, but she did record her presentation. So here we go.
On the State of the World Midwifery Report and what we are doing here in Trinidad and Tobago. Now, I want to start my presentation by thanking our midwives for their dedication and hard work and for improving the life of others, especially during this very difficult period of time, over 18 months in this pandemic. Thank you, midwives. Now, the PAHO, there is a document on NCDs and gender. And it states, a woman's health status also relates to the health and vulnerability of her children. Being born to a malnourished mother increases an infant's risks of undernutrition, low birth weight, and increased vulnerability to NCDs in adulthood. But this is the crunch. Women's health is therefore critically important to the health of future generations. So midwives, we have the future generations in our hands. The State of the World Midwifery Report highlights a few takeaways. So one, it sets new strategic direction for midwifery. Its evidence-based policies and priorities are there to help countries maximize the potential of midwives. It's also a blueprint to ensure that midwives contribute to the achievement of universal health coverage and sustainable development goals. The fact is we cannot overstate the role of our midwives. How do we use the report findings? Well, I just want to take out a bit from what Dr. Tedros said, our WHO Director General. He stated at the policy dialogue that the aim is to maximize the full potential of our midwives, to promote health, to keep the world safe, and to serve the vulnerable. Now, there are a few important roles of midwives that I would like to highlight. We provide a wide range of services in sexual, reproductive, maternal, neonatal, adolescent health. We also help to reduce the risks associated with childbirth. We provide vital support to childbearing women and newborns. We contribute to achieving global health goals by improving sexual and reproductive rights, and also advise on self-care interventions, thereby empowering our women and our girls. The State of the World Midwifery Report highlights several challenges, that there's a global shortage of approximately 900,000 midwives. Also, it's estimated that around 810 women die every single day as a result of pregnancy and childbirth complications. There's approximately one stillbirth every 16 seconds and about 2.4 million newborn deaths every single year. Additionally, about 1.5 million women give birth without the help from a skilled birth assistant. So we need an urgent investment in midwifery, as highlighted in the report. So 4 things I'm going to state. 1, health workforce planning, management, regulation, and working environment. These are things that we need to pay attention to. Secondly, high quality education and training, well-resourced institutions, competent educators and training. 3, midwifery-led improvement into service delivery, developing midwifery-led models of care. 4, leadership and governance with senior midwives positions in government, research, and education. Significant benefits of investment in midwives. By 2035, approximately 4.3 million lives can be saved if we invest in our midwives. We can also promote health and well-being of women, adolescents, and newborns. These are benefits to us midwives. Also, we contribute to the empowerment of women and gender equality. We can also improve economic participation of women in the workforce, and a fully integrating midwives in teams improves access to healthcare services by the most vulnerable. Now let's home in a bit. Trinidad and Tobago. What are some of the initiatives? So number 1, Ministry of Health's draft manpower planning document 2017 highlighted the need for training additional midwives. And also it highlighted the shortage of midwives that exist in our country. Now, this led to the training of district health visitors who were not trained in midwifery. And the reason was to preserve our current midwifery workforce. Secondly, the rationalization of nursing and midwifery education. This identified the need for high quality education and training as stated in the State of the World report. Also, the need for well-resourced institutions, well-trained educators and clinical instructors, curriculum review, which is scheduled for August 2021, and development of the BSc in midwifery program scheduled to start in 2022. Thirdly, we started think tanks over a year ago, where we looked at revalidation for relicensure. Now, this was where we looked at the regulations surrounding relicensure, and also we engaged TTAM, practitioners, the nursing council, and educators, where we set standards for midwifery practice and how midwives themselves can keep up to date and therefore register yearly and be competent in order to continue practice. Fourthly, leadership. Leadership training and updates have been going on. TTAM runs a number of programs, as well as from the desk of the Chief Nursing Officer. We also introduced just a little while ago the leadership line, which provides a safe environment where leaders can come together to share their experiences and challenges and find solutions. Also, we recommend the filling of leadership positions at all levels. Fifthly, the National Midwifery Plan in collaboration with TTAM. We spent months together, where we looked at transforming maternity services in Trinidad and Tobago, a model for change 2020, where we looked at midwifery practice, promoting autonomy, and helping to support our midwives to become better practitioners. Now, as I come to a close, there are certain recommendations which we, from looking at the report, we need to look at every single curriculum. And as I said before, we have already started review of the curriculum. Several of the schools have come together, including our Director of Education. But from this month, we also will be delving more deeply into the review of the curriculum. We also will be looking at our training practices, because there was a report done a couple of years ago by a group of midwives from Europe, and they highlighted that the way we train our midwives, we're not really preparing them to practice autonomously, and that's one of our main goals. So we're reviewing our training practices, also our clinical practice, where we look at evidence-based practice. We need to look at our current practice and ensure that it is up to date. Facilities need to be well resourced and equipped. Our educators and clinical instructors must be well trained and prepared to support our students, so that by the time they complete their training, they would be ready to hit the ground running and be autonomous practitioners. Every midwife must be a mentor, and I have engaged Titan. We're looking at what is it again? Competency-based education. And every single midwife, our aim is that every single midwife would receive this training so that they can support the persons in the clinical area, and thereby that would improve our clinical practice, and also our newly qualified midwives will be more prepared to practice autonomously. And also midwifery-led units. I'm really happy to announce that several of our RHAs have looked at spaces within their RHAs where they can actually provide units where women can give birth in an environment where it is safe, with very little intervention, little or no intervention. So it will be like a home away from home practice, where women can be delivered under the care of midwifery-led service. Now, I close with a quote from one of my favorite obstetricians, because one of the things that is really important is that we work in teams. We are a team. Midwives, we cannot work without the doctors, and the doctors cannot work without us. But Michel Audant, who is a French obstetrician who supports midwives, says, if we want to find safe alternatives to obstetrics, we must rediscover midwifery. To rediscover midwifery is the same as giving back childbirth to women. And imagine the future if surgical teams were at the service of midwives and the women instead, service of the midwives and the women instead of controlling them. So midwives, thank you. And I look forward to us taking back this area that is our domain, not that we are against anybody else, but this is our domain, and where we can become leaders and autonomous practitioners in midwifery. Thank you.
We would like to thank Mrs. Betty Ann Pilgrim for that presentation. Thank you so much, Deborah. Our last presenter is Ms. Bobby Joan Campbell, who is not with us today, and Shirley Curtis, Dr. Shirley Curtis, will present on her behalf.
Hello.
Oh, sorry, I didn't realize.
Yes, she's here.
Okay, thank
She's
you.
here.
Bobby Jo, you can present now.
Let's set up a little bit.
Yeah.
Right there, you put a call on her.
You tell them to get off.
Bobby Jo, you're muted.
Sorry. All right. Good evening, everyone. So I will be sharing with you all this evening the summary report from the Caribbean perspective. And just to share a little about CRMA, the midwifery associations and midwifery interest groups within the Caribbean have joined together to enhance the capacity and competency of qualified midwives, to standardize midwifery education in the region, provide distance learning, to advocate for midwives and their practice, and to influence policies related to midwives, both regionally and internationally. This collaboration resulted in the establishment of the Caribbean Regional Midwives Association in April 2012. Next slide. All right, so the following report is based on surveys completed by 6 member countries of CRMA and will focus on 4 areas: association, education, leadership, and regulation. I must say that not all 6 countries' data that is going to be shared in this report actually contributed to the summary report published by ICMU-FPA. But from the Caribbean perspective, we need to see what is going on in the Caribbean. So in terms of the association, what we have realized from the data is that midwifery associations have between 11 to 61 years of establishment and membership from 30 to 330 midwives. Provision of continuing professional development for all midwives is available across all the countries that participated. We have at least 1 midwifery association that negotiates work or salary issues with government, and at least 1 midwifery association advise government on health and/or SRMNAH policy. So this gives us a little better view. So 100% provide continuing education. In terms of midwifery association providing advice to government, 1 country said yes, 4 countries responded no, and no response from 1 country. In terms of negotiation, rework, or salary issues with government, 1 country reported yes, 4 countries reported no, and 1 country no response. For education, the programs available across the countries are direct entry program, post-basic midwifery training. We have persons completing the program and obtaining a certificate in midwifery. We also have persons obtaining diploma in midwifery. We have persons obtaining a Bachelor of Science in midwifery, but across all the countries, what was the master's level or the doctorate level is not available in any of the participating countries. In terms of midwifery educators, 100% of the educators being registered midwives. 5 countries reported 100% and 75% reported for 1 country. At the end of the training, is the graduate recognized as a midwife? Yes, all countries reported same. In terms of leadership, does the country's national healthcare system support midwife-led continuity of care? All countries reported that, and we found that in all countries, we had midwives in leadership position in the Ministry of Health. We have midwives in leadership position at subnational Ministry of Health offices. We have midwives in leadership position at regulatory authorities, and we have midwives in leadership position at health facilities. However, there is a wide range in the numbers across these countries. So this gives us a little bit more data in terms of the midwives in leadership position at Ministry of Health. 2 countries reported 1 midwife, 1 country 2 midwives, another country 3 midwives, 1 country 25 midwives, and 1 country no response. In terms of the number at the subnational Ministry of Health offices, 3 countries reported 4 midwives, 1 country no midwife, 1 country no response. Leadership position at regulatory authorities, 1 country no midwife, 1 country 2 midwives, another country 3 midwives, 1 country 5 midwives, and 1 country no response. Midwives in leadership position in health facilities, 1 country, no midwife, another country, 20 midwives, 1 country, 21 midwives, 1 country, 55 midwives, and 1 country, no response. In terms of regulation, is the legislation in your country recognize midwives as a profession distinct from nursing? All the countries reported yes. And with this, we also realize that the regulation authority, through this is where midwives are regulated, and they also regulate other health professions. In terms of registration and licensing, midwives are required to register and license in order to practice. And some regulatory authority requires evidence of continuing midwifery education for relicensure. Other functions under the regulation, based on the basic emergency obstetric newborn care that questions that were posed, midwives were able to provide most of these, and midwives were also able to provide most of the contraceptive methods. Right, so just to look a little bit closer, all countries require registration to practice in the country, required to provide evidence of CPD or CME hours for relicensure. 3 countries said yes, and it gave us 50%, and 3 countries said no, puts us at another 50%. In terms of the midwifery workforce, as been brought out by all the presenters before, data was lacking in this regard. So 5 questions were asked about midwifery workforce. 3 countries were able to provide responses to all. So that gives us a coverage of 50% responding. 1 country provided response to 3 questions. 1 country provided response to 2 questions, and another country provided no response at all. So the way forward, when we as CRMA as a body, is to engage other member associations to complete the survey to ascertain their position as it relates to the 4 focus areas, and also to share best practices from one member association to another, to build on the recommendations shared by UNFPA and ICM as it relates to the whole strategic direction for midwifery, to continue partnership with external stakeholders to enhance professional growth as the Regional Midwifery Association. Our contributing countries, the Bahamas, Barbados, Guyana, Jamaica, St. Lucia, Trinidad, and Tobago. And these are the flags of our country. And our top row from left, we see Bahamas, Barbados, Guyana. The bottom row, Jamaica, St. Lucia, Trinidad, and Tobago. Thank you for listening, and we are open to questions or comments as well. That session will be moderated by Deborah. Thank you so much.
Thank you so much, presenters. We had a lot of food for thought. We have listened to the SOMI 2021 report from our presenters. We know that this is a report that looks at midwifery, regulation, association, education, and leadership. And we are encouraged to, when these surveys come around, to participate in them. And we must try to deal with our shortage of midwives, increase the midwifery training, and also let's hope to soon start a master's and a doctorate in midwifery. That is something I'll be looking forward to. The floor is yours, Deborah. You are the person that's dealing with any questions being asked.
Okay, thank you so much, Sonia, and thank you to the panelists. A reminder that if you have any questions for the panelists, please put it in the chat. We have one that was directed to Devery, but if anyone else wants to come in after Devery is answered. The question was, Devery, do you think that the best way forward would be to have one common midwifery curriculum for the Caribbean, as well as one common midwifery licensing exam?
That would be good, but I think personally, because it's now at the university level and we have different university working together, each curriculum would be a bit different because you have to take in the cultural practices that happens in each region. So it will be tweaked a bit. Whilst the examination could be one, some tweaking would be there because it's dependent on the cultural practices in your country. But again, because it's not a most of the, not most, like in Jamaica, now midwifery now is like at the university level where they're getting a degree. They're going to want to hold on to their curriculum because that is how they make their money, by the number of credits. Yeah, unfortunately, that's how it is. So whilst it would be nice to have one curriculum, fine, but what could happen is that the core part of it, just like the ICM competencies, the core midwifery competencies should be seen coming out from each of these curriculum, and that would be best practice then for us to have a regional exam.
Thanks, Devery. And yes, I did wonder if Pandora or Sandra would want to comment on perhaps, as Devery just said, on the core competencies from ICM, and then, you know, room for the individual variations based on countries, etc. But at the core, the midwifery curriculum. So Pandora and Sandra, would you want to comment on that?
Deborah, I think, you know, what's been said makes a lot of sense. It's not going to happen overnight. And so the planned work that we heard about in Trinidad, and I would imagine in some other countries, to review curricula to see that it meets the minimum standards, would be sort of a first step towards that possibility of a uniform curriculum. I'm not in education, so I probably should not presume to provide an answer from UNFPA, but that seems to me would make the most sense in the short term. But the history, I'm reminded that in the early days when they were began to talk about a nursing regional nursing exam, having a standard curriculum, probably that wasn't what it was called, but having a basic curriculum was an early step in that process.
Thank you, Sandra. Pandora, did you want to add anything?
Just some thoughts that there is a precedent, I think, that has been set for that with what is happening with the regional nursing body exam. And when you look at curriculum, and when you look at regional curriculums, it's that not that you would have one curriculum for the school, but so long as the curriculum matched to the basic competencies, when we go back and look at some of these other broader certification and national board exams, the exams are matched to the baseline competencies. So when in terms of test question writing and item analysis and the boards that are brought together to do that, that's very much how it's pitched at a basic competence level. And that is where the input, if we were theorizing this, of the different educational institutions could be they on board to play to harmonize that alongside. There's a lot of work that's always done with different test maps. So that the final examinations are actually mapped to the curriculum. And then each individual school, I think, as you're going through your curriculums, you can match it to the ICM competencies, which then is mapped to what we use forward for the exam prep. So I actually think it is an attainable solution that might not be as far away as you think, based upon what is happening globally and regionally.
Thank you for that. And as you said, we do have the RNB that has the regional nursing curriculum and the regional nursing exams. That was the only question. And I suppose that in the essence of time, if nobody else has any other questions, then if any of the panelists have a burning thing that they want to say in closing, please take the opportunity. And no? So if not, then I just want to thank all of you. and to hand it back over to Sonia for closing and moving on to the next session. Thanks, everyone.
Thank you so much, everyone. It was a lovely presentation. I really enjoyed learning about the report and also about the Caribbean perspective and the amount of work. We have much more work to do, but we can do it. We have the ability. We are midwives and we save lives. The future generation is in our hands. Right now, as we get ready to go into the next session, this is our time to stretch. We need to stretch. And stretching doesn't just mean our hands, it also means our legs as well. We need to stretch our bodies, get the blood circulating. Pump. Move your hands, like bend those hips, right? So I hope everyone stretch, even if you want to sit down, stretch your legs, move your arms. I hand it over to the next moderator, Diane Henry Ernest.
Just before Diane starts, I'd just like to say, I've seen in the chat that a number of persons are asking about CME hours. The link for CME hours will be put in the chat at the end of the educational session. You'll be required to click on that link, answer the questions, and you will get your certificate with your educational hours. Okay, so we don't take the information out of the chat. You will have to answer the questions in the link, and then it's not a don't worry, it's not a quiz on what was presented, so don't be afraid. But you will be required to answer just a few questions for us about the presentations, and then it's about 200 persons on the chat, so you have to give us a couple of weeks before your certificates will start rolling out. Okay, so by the end, in 4 weeks, let's say, you should have received your certificate. Okay, so thank you very much, and I'm happy to see that persons are actually interested in their CME hours. So over to you, Diana. Thank you.
Thank you, Dr. Curtis. Thank you, Dr. Watson Miller as well. You heard that I am Diana Henry Ernest, and I am from the beautiful island of St. Lucia. I am very happy to be here with you tonight and to lead this section, session 3. In this session, we will have 3 activities. We will have a presentation on JDEL by Dr. Christy Thomas Mendes. We will also have a discussion with a very interesting gentleman on a male perspective of family planning. And then we will have the last presentation on parenting styles in the 21st century. Okay, so we will not waste any time because we know that time is already against us. I will present the first, in fact, introduce the first presenter. Dr. Christy Mendes graduated from the University of the West Indies, St. Augustine campus.
Okay, I'll manage.
Faculty of Medical Sciences in 2010. She has been practicing obstetrics and gynecology since 2011. She became a member of the Royal College of Obstetrics.
And Diane, you're muted.
I don't understand. So I have not, nobody has.
You're good. Yeah, you have to, yeah, we missed what you were saying. Yeah.
Okay. Well, thank you very much, Dr. Watson. And I am Diana Henry Ernest from St. Lucia. I am a midwife by profession and also an educator. I am delighted to be here with you tonight to moderate this section of our CRNA AGM. Okay, in this section, we have 3 presentations of free activities. And the first presenter will present on a method of contraceptive called JDEL. And the second one, we will have a discussion with a very interesting gentleman on his perception of family planning. And the last one will be a presentation by Ms. Cicely Clark-Richmond on parenting styles in the 21st century. Ladies and gentlemen, I am delighted to present or to introduce my first presenter for tonight, Dr. Christy Mendez. Hopefully I am pronouncing the title correctly. Graduated from the University of the West Indies, St. Augustine campus, Faculty of Medical Sciences in 2010. She has been practicing obstetrics and gynecology since 2011. She became a member of the Royal College of Obstetricians and Gynecologists in 2016 and completed her postgraduate Doctor of Medicine degree in obstetrics and gynecology from the University of the West Indies in 2019. She is currently employed at the Sangri Grand Hospital as an acting senior medical officer. She has always taken part in teaching sessions of the junior doctors and midwives as she values the importance of continuing medical education. Currently, she is one of the principal investigators in a pilot study involving the introduction of JDEL implant into Trinidad and Tobago. Ladies and gentlemen, please help me welcome Dr. Christy Mendez.
Hi, good night. It's actually men.
Dr. Christy Mendez?
Yes.
Men's, sorry.
Yes, that's okay. So I'm very thankful to be here tonight. Thank you for the opportunity to present. I will try to keep the presentation as short as possible. I think I'm allowed 15 minutes. I think what's important with respect to the implant, it's a new form of contraception that we are introducing in Trinidad. I'm not sure if other Caribbean islands have been using it, but as midwives, it's important to know that this form of contraception is very beneficial for our postpartum patients, and it ideally should be inserted prior to their discharge from the hospital. So training moving forward, it will require training with respect to doctors as well as midwives to input the implant. And an important aspect before the implant is used is the counseling of the patient, which is what the presentation is a bit about. So I'll give you a little background with respect to what the implants are. Right, so in 2016, the Ministry of Health, Trinidad and Tobago, along with PAHO and the UNFPA, sent a team to have training done in Guyana with respect to this implant introduction. Myself, along with Ms. Davis Gentle from the ERHA, accompanied Dr. Wheeler and Katian Greenidge Utley from the Tobago Regional Health Authority. This was a 3-day course of both missions. Right, the purpose of the course was for us to be introduced to the counseling as well as inputting the implants and then coming home and passing the information along. Right, so as we all know, there are different forms of contraception, barrier methods such as condoms, diaphragms, hormonal forms of contraception, which will include your OCPs, injectables, vaginal rings, patches, and then we come to the long-acting reversible contraceptives, which we know as LARCs. And these will include your IUCDs, such as your Marinas or your copper devices, and the implant. So the implant, these are considered long-acting because they last for a number of years. There are different types of implant, and this one is a 2-rod system that lasts for 5 years, right? There are also 1-rod implants that last for 4 years,
And these rods are flexible, small rods that are placed just under the skin of the upper arm. They are highly effective and they provide long-term pregnancy protection. How do the rods work? Just to give you a quick rundown, it prevents ovulation in 45 to 85% of the cycles. It thickens the cervical mucus. It suppresses maturation of the endometrium. And there's a decrease of natural progesterone production from the ovaries. It is more than 99% effective, right? The annual average pregnancy rate over 5 years is less than 1%, which is very important when we are counseling our patients prior to insertion. So they are levonorgestrel implants, which is the same hormone that is found in the Mirena. There is no estrogen, which is the reason why it can be used in our postpartum patients or any patient that has a high risk of developing a DVT or a blood clot. This is a good form of contraception. And it's done in an outpatient clinic setting, so it does not need to be conducted in an operating theater.
I remember.
Right, just a little bit on the pharmacokinetics. The daily release is approximately 100 micrograms per day. And this is over the first month. Following this, it drops to 40 micrograms per day at 12 months and then 25 micrograms per day at 5 years. And this graph shows that for the 5 years that the Jadel is placed, there is more or less a steady mean serum level of the hormone throughout the system, throughout your body. So there is that is what makes it so effective and the failure rate so low. If we look at the contraceptive efficacy, the Jadel has the best contraceptive efficacy. It's even more efficacious than the Mirena. With a typical use, it's 0.1 compared to the perfect use. If we compare this to, say, a copper IUD, this number is increased to 0.8 with a typical use. For whatever reason, if the coil slips, if it's removed, and well, the ones with the lowest efficacy would be your condoms, male condoms, as well as female barrier methods such as the diaphragm. Right, so the advantages, as I said before, it's highly effective. One insertion of a Jadel replaces approximately 1,800 days of pill taking. Right, after the removal of the Jadel, the levels of the hormone drop quickly and fertility is restored promptly, which is something that we also need to counsel our patients about. There is no delay in action. There is no interference with daily activities. It is very comfortable and the rods are not very noticeable in most women. And it is one of the lowest doses of any hormonal contraception. And as I said before, there is no estrogen. So what are some of the side effects? From the study that we conducted, we found that counseling the patients is one of the most important things to ensure that there's a low fallout of the Jadel, meaning a low number of patients coming back requesting the Jadel to be removed because of side effects. So it's important we counsel the patients and tell them what to expect. Therefore, they would not ask for it to be removed within a few months of it being placed. So one of the most common side effects with the Jadel due to the hormone will be menstrual bleeding. This changes, such as with the similar changes to when you have a Mirena placed. So some women may get increased duration of bleeding, irregular periods, spotting. The important thing to counsel our patients about is that this usually settles off within 3 to 6 months. As your body gets used to the hormone, it tends to settle out, and most women are very happy once they reach that point. Right, after a year within 1 year of use, 27% of users have regular cycles, but by the 5th year, this number goes up to 62. Right, the irregular cycles within the first year of use, 66% of users have irregular cycles, but by the 5th year, this number decreases to 38. So it is really a matter of giving the Jadel time to adjust, your body to adjust to the Jadel. Some other side effects would be as with any progesterone, so headaches, bloating, acne, weight changes, breast tenderness. And complications, which we need to be aware of when we are inserting the Jadel, we have uncommon complications, which would be infection at the insertion site. It needs to be inserted under sterile conditions. Difficult removal this is a uncommon complication, and it really only happens based on how it's placed. When I'll show you a video with the placement, it needs to be very superficial so as to allow for an easy removal when it's time to have it removed. A rare complication is expulsion of the implant, and this tends to occur as well if there's an infection at the site. An extremely rare complication is that there's migration of the implant to another part of the body, but this is very rare, right? So if someone comes to you with a Jadel place and they complain of irregular bleeding, the answer is not removing the implant. There are things that we need to do first to try and improve the bleeding issues. So firstly, we need to reassure them that this is normal and it most likely is going to improve it in a few months. If there is no relief or they wish to have immediate relief, we can give them some mefenamic acid or even an oral contraceptive pill for a few months to see if that helps. And if the patient have not seen a period at all, firstly, we need to ensure that there is no pregnancy, especially if the implant was placed and they never saw a period since, then we ensure that there is no pregnancy. If the patient is pregnant, we advise that you remove it. And if there is no pregnancy, we just reassure the patient that this is normal as well. Heavy or prolonged bleeding, the exact same treatment as before, NSAIDs or combined oral contraceptive pill, as well as hematinics to make sure that the patient does not become anemic. All right, so which patient is suitable for an implant? As I said before, our postpartum patients. So midwives, we all need to learn how to place these implants because we are all going to be using it. It's a very, very good form. And a lot of women prefer this rather than having an IUCD placed postpartum, right? Teenagers who are sexually active, they are also a very good group of women to target for this sort of contraception. Women who wish to space their pregnancies, and as I said, anyone who has a contraindication to the use of estrogens. So anyone that has a clotting disorder, known blood clots or PE, then they can use this safely. So the woman with an increased BMI, there has been noted to be a decreased efficacy after 4 years. Women that are over 80 kilograms, they may need to have the implant replaced after 4 years. One way to know that the implant is no longer working is that someone who may have had very light periods with the implant and now they have now suddenly started to see heavy periods again, or their period may have returned. So this is one way to know that the hormones are no longer effective. Right, and there are some contraindications to using the implant. The only category for contraindication, meaning that it is definitely you cannot use this, is someone who has breast cancer. Could be anyone that has an acute PE anticoagulation, they can use it. But if it's a new blood clot, then it's not advisable. Heart disease, cerebrovascular accidents, migraines with auras, anyone with a history of breast cancer, unexplained vaginal bleeding, cirrhosis, or malignant hepatoma, then this meaning that if you can find another in this. And with respect to breastfeeding, it is safe, it is a category 2. So as I said, postpartum, woman is breastfeeding, they can have the implants placed. It does not decrease the milk supply. So how do we start the Jadel? Basically, once the patient, if they have no hormonal contraceptive use in the past month, insert it within 7 days at the start of the bleeding. Basically, to summarize these slides, because there's a few slides with how to start the Jadel, you have to ensure that the patient is not pregnant. One way to do this is to insert it within the first 7 days of their cycle. That way we know they're not pregnant. Otherwise, then we would have to do a pregnancy test to ensure that they are not before inserting. And as I said, it is placed just under the skin on the inner side of a woman's upper arm in the shape of a V. We use local anesthetic and it is done under sterile conditions. right? This is a picture of us in Guyana doing the training. This was the head of the Ministry of Public Health Department of Maternal and Child Health, Dr. Hamilton, and she received the implants that day during the training session. This is me removing an implant from one of my colleagues. And now I'm going to show a quick video on the insertion and removal techniques. Are you all hearing the audio?
Not yet.
No. Okay, I will just talk through what is going on in video because I'm not too sure why you all are not hearing the audio.
Maybe you can put the link in the chat and persons can watch it later.
Okay, sure. That's fine. I can do that. Just wanted to show you quickly before doing that, just the placement.
Or you can talk us through the video as you play it.
Yeah, I'm just going to show where the placement is. So basically we position the patient's arm like this, in this position with her lying on the bed comfortably. She already got her local anesthetic, and it's 4 finger breaths from the medial epicondyle, which we'll see the nurse do in a short bit. So she's just testing to make sure that the anesthetic is working. And I just want to show you where her fingers are being placed. That is the removal, sorry. Right. So look at her hand placement, the medial epicondyle, and it shows you the exact how to insert the implant, the Geister access. So that brings me to the end of the presentation, and I believe there will be a question session afterwards.
Thank you very much, Dr. Mins. Yes, the questions will come after all of the 3 presentations are done. Okay, right now. Yes, everyone, we are going to have our second activity for this session. It's a discussion with a gentleman, Jason Malcolm, on his perception about
Diana, we're getting a lot of feedback.
I don't know why.
Ask Dr. Mins to stop sharing her screen.
Oh yes, that is what is causing that problem. Dr. Mins?
Sorry.
Yes.
Right.
Thank you so very much. Yes. Okay. Mr. Jason Malcolm is a father of 3. He's a husband, and tonight he has agreed to speak with us on family planning, his perception. I invite Mr.
Diana,
Jason.
we're still hearing a lot of background
She
noise.
has two devices or another device close by. We are getting feedback.
No, I only have one device on. I am not sure why. I don't know why this is happening.
I just introduce them and we'll see.
Okay, well, the next presenter is a very interesting gentleman I have said before, by the name of Jason Malcolm, where we will be discussing, or he will talk to us about his perception on family planning. He's a father of 3 and a husband, and I am very delighted to have this discussion with him. I welcome Mr. Jason Malcolm to have this discussion with us tonight. Mr. Jason Malcolm.
How you guys doing?
Hi, good night.
Good night.
Welcome, welcome, welcome.
Thank you.
All right. It is always a pleasure when we get to speak with the husbands, the partners of our clients, because we advocate for family. For
Diana,
A lot of feedback.
we can hardly hear you. There's a background noise.
There's a background noise.
Yeah. What about the headphones? You didn't try the headphones?
I have them on.
But that might be the problem.
Take the headphones out, try it without.
Problem. Pull it out the computer. Pull it out.
Okay, are you hearing me any better?
No, take it out from the device.
Yeah, take
your
device. Yeah. Don't use your headphones. Do it without the headphones. Yeah, take it out the computer. And try that.
Are you hearing me any better?
Still hearing the noise.
It's still there.
No. Let me try something. Just give me a second again. Is it better now?
Yes.
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 Oh, thank you. Let me see this now. Okay, I don't know how much you heard, but I am going to repeat myself. I'm going to welcome Mr.
No, we got it.
No,
we got it.
Okay, so we can go
ahead.
right into it now. Okay, then. Okay, Mr. Jason.
I'm here.
Malcolm, most times what happens in the Caribbean, what the literature is telling us, is that women are the ones who actually participate in contraceptive methods to control the number of children that they have. It's almost like the burden is on women. Can you share your thoughts with us on family planning?
Well, for the most part, the burden is on women, but as a father and someone that has a lot of responsibility, you have to, I had to take the responsibility in my hand to, not keep making babies, because we are considered a middle class. I felt like everybody should practice contraceptives and have, based on how many kids you want or how many kids you can afford. But as middle class people and poor people shouldn't have a whole bunch of kids, because we cannot afford to educate them. We cannot afford to feed them. We cannot afford to be, I'd say, a dad to too many kids. So I felt we should, I took the responsibility of not having too many kids because I cannot afford these children, and the more kids you have, the more your responsibilities are. And it's different in the Caribbean as it is in the US. In the US, all the responsibility falls on you in terms of everything, daycare and everything. In the Caribbean, you probably could send your kid to the neighbors. Nobody does that here.
You're coming in with a lot of feedback as well, but I'm only hoping that everybody is hearing you. Thanks for sharing that with us. So I get from you that you actually look at family planning as a shared responsibility between a man and a woman. Yes, I thank you for that. Yes. We know that the number of contraceptive methods for men are limited. Can you talk to us about the withdrawal method as a contraceptive method for men?
Well, the withdrawal method, it works to a point, but then it also doesn't work because there is also premature ejaculation where you could make a baby that way. A lot of people felt like, okay, this is the moment is coming, and that's the time you withdraw. You don't have to. You could make a baby long before you get to the withdrawal method.
Okay, so it's a very challenging method, but
Very.
it's available. And would you agree that most probably it takes a lot of control from the man and the woman as well?
It does take a lot of control from the man's perspective, because if you lose your mind, you may end up with 20 some odd years of responsibility that you can't afford.
Okay. Can you talk to us about the use of the condom? Because, you know, there are so many things being talked about regarding the condoms. So can you give us your thoughts?
Well, condoms are very useful, but if you're with your person or your partner for a number of years, after a while, the condom becomes I'd say like something you think of like later, or sometimes you're like, oh, I don't need to buy that. No, you know, I trust her, she trusts me, and then, you know, one thing happens, or sometimes you'll have a condom, but then the condom might be too small or too large, then you still have issues. Then you might just discard the condom, and then you know, end up with a baby that you didn't prepare for.
So I'm hearing from you, and not actually articulating it, but I'm hearing that you advising that men should wear the correct size of condom. And of course, I'm going to add a little, maybe they should also store the condoms properly as well. What are your thoughts on that?
True.
Okay, all right. So you have had a vasectomy, and I wish to talk to you about that. Why did you choose vasectomy as a birth control method?
Because when I knew I wanted 3 children, they didn't happen the way I planned it, but I end up with the 3 children I wanted. And I had all 3 children by the time I was 30. So when I was getting older, closer towards 40, and I decided that there's no sense in having children over 40, and all the other methods. I saw the list, and I'm surprised that vasectomy is all the way down on that list. Vasectomy should be like maybe 1 or 2 up on the list. But I feel vasectomy is one of the safest methods of not making any more babies, from my perspective.
Do you have any regrets?
No.
Of having performed one?
No.
Oh, okay. So how do you feel about having performed a vasectomy? Does that remove anything like your manhood? Like some people might have an idea in their heads that they do not want to perform it because they might think they might no longer be a man. Can you share your thoughts on that?
There's no change in sexually. There aren't any changes. To me, there aren't any changes sexually. But the problem is with a lot of us Caribbean men that we are mass thinkers. So we felt like we're losing our manhood by you know, it's a small incision in the vast difference. I watched the surgery as it was being done. It was nothing to it. And after healing, you're right back to normal as if nothing happened. You just know that you're not going to make a baby.
Okay. Do you experience any pain during sexual intercourse?
No, I do not.
Okay. Taking into consideration, women perform TL to control their fertility. What are your thoughts on TL versus vasectomy?
Tubal ligation.
Well,
yes, tubal ligation.
Right. Well, see, a lot of us men expect the woman to take on all these responsibility, But then some women are very hesitant, and because of all the issues that comes with a lot of these things that women have to do. Like, for example, I saw that insertion into the arm could lead to excessive bleeding and stuff like that. So women are very hesitant. I did my research on this process. I watched videos, I looked at blogs. So, and I haven't seen many negatives in doing it. So I just decided that's the best method. I don't have to rely on somebody else I took responsibility in my hand, knowing that I cannot afford to send 5, 6, 7, 8, 9 kids to college. I'd love for my children to have an education. And if I keep having these kids, then whatever I have has to be shared between more children than I have already. So I would recommend that more island guys be educated on this and think about it instead of having 9 children. Because I know a person that have 9 children.
I am so happy to hear you speaking like this. I wish more men would think like you, because I know the burden of responsibility would be shared when it comes to family planning and family developing and having their families. Any final thoughts? Yes, you wanted to make a comment. Go ahead, please.
Listen, my only final thought is I commend the job that you guys do, because I was born at home in Jamaica. Mm-hmm. So if it wasn't for a midwife, who knows? I very much appreciate all the work that you guys put in, all the effort, and this coming together with all the different islands or the different countries. I really commend you guys on this, and keep up the good work. Miss Gentle, I know you're in there somewhere, one of my BFFs.
Gentle is hearing that. Yes. And all my midwives, you know what? I know they are smiling and they're laughing and they're all applauding, because they are happy to hear you say this and speak about midwives in that light. And I want to thank you so much for accepting to have this discussion with us. Honestly, there's so many questions that we want to ask, but we do not have the time to do that now.
Well, so I'm always here somewhere. So, and Mrs. Gentle knows how to find me. So, at any time we could probably get back into something if needed.
Noted. So we will utilize you as the needs be. We thank you so much, Mr. Malcolm, for participating in this discussion tonight with us. It was very enlightening. And
you guys are most welcome.
Don't go away, because I believe some persons may want to ask you questions. And of course, I will encourage persons to ask questions that are not knowledge-based questions. It has to be on his perception on contraceptives. Thank you very much, Mr. Mason.
You're welcome.
All right. So we're moving right along with our next presenter, who will be presenting on parenting styles in the 21st century. I introduce Cicely Clark Richmond. Mrs. Cicely Clark Richmond is a former executive with over 25 years of experience in the areas of communication, media relations, program production and development, supervisory management, customer service, leadership, and motivating others. Mrs. Clark Richmond holds a bachelor's in communications from Queens College, Queens, New York, and a Master of Fine Arts from Brooklyn College. In her professional career, she has worked with the Caribbean Broadcasting Corporation in the capacity as presenter, assistant program manager, and head of TV. Mrs. Clark Richmond has also worked as an information officer at the Barbados Government Information Service. After her retirement from the CDC in 2017, Mrs. Clark Richmond began producing and hosting the Pause for Parenting radio program in 2019. She was appointed to the position of director. Here she is responsible for the operation and management of the daycare, counseling, as well as oversight of all other initiatives. Under her tutelage, Parados is and will continue to evolve hand in hand with the dynamism of our world today, reaching the parents of our society wherever they may be, changing communities, one family at a time. Ladies and gentlemen, please help me welcome Mrs. Cicely Clark Richmond to do her presentation. Mrs. Cicely.
Thank you very much. Good evening, everyone. Madam President and your team, I want to thank you so much for the opportunity, for the invitation to Parados. Let me just tell you quickly a little bit about Parados. Parados stands for Parent Education for Development in Barbados. We've been around for almost 50 years, and Parados was established to assist parents with skills and knowledge that they need to become the best parent they can be. I've been asked to speak to you for the next 15 minutes on parenting styles in the 21st century. And I'm going to share with you what I believe parents and anyone who is thinking about becoming a parent need to know so that they become the best parent they can be. But before I do that, I want to share 3 points that I believe is important that we all recognize when it comes to parenting. Effective parenting requires time, educational support, and dedication. But most of all, it takes love, which produces patience, understanding, and commitment. Parenting is not only a right, it's a responsibility. Despite the fact that millions of people become parents every year, parenting remains one of the most difficult and challenging jobs anyone can undertake. Think about it. You are taking an infant, a totally helpless person, and assume full responsibility for raising him or her into what? And that is the question I want you to answer this evening. Here are the 3 things that I think, the 3 parenting styles that I think that anyone thinking about becoming a parent, and if you are a parent, that you need to know, you need to consider. First of all, you need to conduct a real analysis. What is a real analysis? Real is a realistic, educated analysis of your life. First of all, who am I? Who am I as a parent? When you're on a plane, you're asked to first put on your own life jacket. And when you are thinking about becoming a parent, or even if you are a parent at this point in time, you need to know exactly who you are. You need to do some self-analysis. Ask yourself, who am I? What are the things that I like? What are the things that I don't like? What are the things that trigger me? What are my strengths, my weaknesses? We need to understand that if we're going to become parents to children, we first need to know who we are. We first need to know everything we possibly can about ourselves, to be comfortable with ourselves. We need to know what our standards are, our values are. As I said, your strengths and your weaknesses. You need to be honest with yourself. You need, in fact, to fix yourself first. Children come today programmed. We're the ones that have to find out the password. You don't have 18 years to find out the password. You have to do it quickly. Therefore, you need to know who you are. You need to be comfortable in who you are when you are taking on the responsibility of becoming a parent. If you are a parent, you need to ask those questions as well. You need to ask, who am I as a parent? Am I the parent that is loving, caring, setting a positive example for my children? Or I'm still trying to figure me out? That is why it's extremely important that before you take on the responsibility of parenting, that you understand who you are comfortable in your own skin, so that you can become the best parent you can be. As I said, you do not have 18 years to figure the children out today. Today's society, today's children, they come already programmed. All you have to do is to find out what is the password. They're already locked on, they're already plugged in. The second thing I would like to suggest that you do is to begin with the end in mind. Begin with the end in mind and work backwards. Ask yourself, what kind of adult do I want to produce? What about my child that I want to be most proud of when he or she is an adult? Ask yourself those questions and work backwards. If you want to produce a doctor, a lawyer, a scientist, ask yourself, what do I want to produce? Do I want to produce a human being that is full of integrity, have empathy, loving, have emotional intelligence? Or do I want to produce a doctor, a lawyer? We know there are doctors who can walk in an office and don't speak to patients. We know that there are scientists who don't care about anything else but science. We have to, as parents, seriously consider what we are doing to our children. We have to have a goal. We have to have a purpose. We have to decide what it is, what kind of adult we want to produce. And then once we get to that point, once we understand what it is that we are raising, who it is we are raising an adult. We're raising somebody hopefully that we're going to be proud of, that is going to make a contribution to the world that they are living in. So let the children choose what career they want to, but you as the parent concentrate and focus on developing a human being who is well-rounded, who cares about the environment, who cares about other people, who has emotional intelligence. And I guarantee you, once you set that goal and you work at it and you work backwards, so that every action that you perform in your home, wherever you are, it is aimed at producing an emotionally intelligent human being who cares about people, who understands what it means to be a human being and an adult. And the third point I want to leave with you, if you don't know God, if you don't know Jesus, if you don't care about anything relating to him, I suggest that if you're raising children in this 21st century, that you need to get to know him. He will help you to become the best role model you can be to your child. It is not going to be easy. It is the most difficult job you can ever undertake. But I guarantee you, if you know who you are, if you understand, you may not understand 100% about yourself, but you have to know who you are. You have to know what your values are, your strengths are. You do not have time figuring yourself out and figuring out the child as well. So you have to make yourself as comfortable as you can in terms of your knowledge about you. And if you make up your mind and you work with your partner, let your partner take that analysis as well. A realistic, educated analysis of who you are, where you are at, what kind of parent you want to be, what kind of adult you want to raise. These are the questions that we need to ask ourselves. Our society, our world is in a situation that we as parents have failed them. And we have to understand that. We have to admit it. We have failed our children. We've had them not understanding who we are, not knowing what to expect, not preparing ourselves properly. We cannot use the same tactics that our mothers and fathers used to raise us. Yes, we cannot throw out the baby with the bathwater, but we have to understand that children are human beings. They demand and they need respect, and we have to love them and care for them and be the best parent we can possibly be for them. So sit down with your partner, first with yourself, but then sit down with your partner and decide, what kind of human being do I want to raise? And once you've got that down pat, then you work back, because it will control your actions. It will control how you speak to your child, how you take care of your children. You have to have a goal. You have to have a purpose. You have to have a purpose, a reason. And when you understand what that goal is, what kind of human being you want, anybody can be a doctor or a lawyer nowadays. It doesn't, I mean, I'm not disputing the educational, requirements, etc. We can be almost anything we want to be. But if we look at our world, we can see a world that is hurting. People don't care anymore. Everybody is about themselves. So what kind of human being am I raising? Do I want my child to become? Do I want to be proud? I want to carry on my legacy. Hey, you as a parent, that's your responsibility. Nobody can take it from you. And don't let anyone take it from you. You have a responsibility to any child that you bring into this world. Set the goals. Put on your life jacket first. Take care of you. And then go about directing, caring, loving, and raising a human being that will care for himself, people around him, and most of all, his God or her God. Thank you, ladies and gentlemen.
Wow, wow, wow. Thank you so very much for this powerful presentation, Mrs. Cicely Clark Richmond. Know yourself, and of course, be prepared before having children. Okay, so we're moving right along with our questions and answer. And I'm sure you have written all your questions in the chat. And to drive you through this process, I will call on Ms. Cheryl Walrod. I only hope I pronounce the surname correctly again. Ms. Cheryl Walrod.
Good night to everyone.
Good night.
A very enjoyable session, very informative. And we want to thank the presenters. The topics were very well presented, and I'm sure that we have learned. Are there any questions?
Cheryl, I had put one in the chat, but I'll say it. Thank you very much, everybody, for their presentations. But I did have a question for our male perspective on family planning, whether or not his wife was in agreement that he should take the lead in family planning. Is Jason still on?
I'm here.
Yes.
Well, we're like 2 years apart, and we both were getting up there in age, so we came to the agreement that we have to do something to prevent having children in our 40s. So yeah, we agreed up on it. She drove me there at to and fro that day too.
The reason I asked is because I had an experience where the man had agreed to do it, and when it was time for it to be for it to be done, and we were going through the steps, and then we said at the end that you know, you have to wear a condom afterwards because you need a certain amount of ejaculates before it's really in effect. The woman,
Right.
let's say, condom. I don't want my man wearing no condom. If that's what happens, then I will tie my tubes. And I was so upset with her. I was all excited that I was going to get this man to tie his, to have a vasectomy. And she changed her mind at the last minute. So I was just wondering what was your wife's response? And I'm happy to hear that she was all on board.
Yeah, and you know, afterwards we actually practiced the withdrawal. Until I went back for the final test
to be sure.
Right, to be 100% sure.
Mm-hmm. Okay.
It's not a big deal, but it's reversible in most cases. But at this age, I couldn't see myself running to Costco's or Walmart to get diapers and wipes and having a stroller. You know,
you have it bad. You have it bad. Any other questions? Sorry, go ahead, Cheryl.
Any other questions, please?
Cheryl, somebody asked in the chat of Jason what his friends thought of what he did.
I'd say 99.5% of them wouldn't do it. It's kind of like, you know, with the vaccine. Most people I know won't do it either.
Any other questions in the
chat?
chat?
See any other questions in the chat?
I had just commented that we had an introduction to all the speakers, but we didn't have an introduction to Jason. So I was just kind of curious, you know, as to, you know, his background and, you know, his upbringing, if that had anything to do with his decision to responsibility.
No, I grew up in Jamaica, and one of my reasons for doing it also is that in my family, my grandfather, my father, my uncle, a lot of male figures in my family seem to have children as they get older. Like my father got a son when he was in his 50s. My grandfather, I think, the same thing. My uncle, the same thing. I didn't want to be part of the statistic of just keep going with everything that is happening in my family. So that's why I decided to do it early before I got to 40. So I'll raise these 3 children and they'll become adults, and I'll still have a little bit of life left in me. And I'd love to see a few of these countries, including a few of those islands that you guys are from, maybe St. Lucia one day, Trinidad for sure, you know. So I can't keep having children. I'd love to have some travel money left over after they are gone.
I don't see any more questions in there.
No more questions, Cindy.
Oh, there is a question there.
There's a question.
Read the question, Diana.
What does the vaccine have to do with the vasectomy?
It doesn't have anything to do with the other. I'm just saying that people are very hesitant with all of these things that comes along.
Okay, of course. Great, Jason.
What's question? Can I go ahead and ask
There's another question. Are there any pre-tests to be done? I believe this is to Jason.
Can I go ahead?
Yeah, go ahead, Sharon.
Right. I was just asking Jason. My question is to Jason. Do you have any? You didn't say where you're living, but in your area, do you have an idea of the like percentage of persons there, men, who actually does a vasectomy? Maybe you know, is that done in your region? Does is it something that is done, you know, frequently?
No, I live in New York, but you have every person have to take responsibility for their own actions and for their own pockets. A lot of us, a lot of male figures around here have a lot of children. I live in like close to the Bronx area, a lot of Jamaicans, a lot of Caribbean people, a lot of island people here. And a lot of them won't, you know, have two or what you call 2 or 3 baby mothers, 4 baby mothers, 5 baby mothers. Some people have 5 children with 4 baby mothers. That's your money stretching too thin by having to support this many households, and especially, and if you're on child support, it's even worse because that's the government is taking theirs first before you get any of the money you earn.
There's another question there.
So proud of you. Continue.
Thank you.
Everybody.
Cheryl, there is another question there.
Don't see any other questions.
Read it, Diana.
Okay, how long was your recovery period, Jason?
I think it was I think it's about 6 weeks. In 6 weeks, I believe you go back for the final exam where they do where they check the sperm to make sure that they check to make sure that you're not able to fertilize any eggs.
Cheryl, I have a question for Miss Cecilia Clark Richmond. Miss,
you may go ahead.
Richmond, have you noticed, or what would you say is the impact of COVID-19 on parenting skills?
Definitely it has impacted parents, because a lot of parents are under a lot of stress, having lost their jobs, online learning. Both those two areas I think would have serious impact on parenting. You know, it's one thing when you're working, everything is fine, but when you've lost your job and you have a child that you have to, you know, take care of, and now you would normally have sent the child to school, now the child is home, you know, you maybe have one laptop in your house, so you may have one computer, you have 2 children, 3 children, and they all have to go to school online. All those things would have affected parents, you know, have been affected parents for sure. So yes, COVID definitely would have been impacted.
Thank you.
Any more questions, please? Well, I want to thank all of the presenters in this section again, and thanks to all those who gave their input, asked questions, or in some way contributed. And I will turn the session back over to the moderator, please.
Any announcement, Dr. Curtis, who is doing that?
Hi, I think Chanel is doing the vote of thanks.
Evaluation. Yes.
Right, and evaluation. But in view of announcements, just to say that tomorrow night is our business session, and we would hope that you would all join us if you are members of CRMA, meaning that your country. So if you saw your flag tonight at the opening ceremony, that means your country, your country is considered a member of CRMA. Now I noticed somebody said, "Oh, you missed our flag." No, we did not miss your flag. They were the flag of members of CRMA. And so if you did not see your flag, we would encourage you to email us at CRMA. You can go to our website or you can go to our Facebook page and contact us and let us know that you are interested and we can take that next step. Okay, because we welcome all of our Caribbean countries, but some persons are not. And if you notice that your country, you saw the flag, but you have not seen any activity, then you might still want to contact us so that we can work together to ensure that your country become more active regionally or locally, as well as regionally within CRMA. Okay, I think, so the link for the meeting tomorrow, your presidents or group presidents or leaders will be sending out the links. If you haven't gotten it, like I said, you can message me, direct message me in the chat, and I will tell you who that responsible person is within your area. Thank you very much. I think Chanel is up for evaluation and vote of thanks. Chanel?
Yes, thank you, Dr. Curtis. I invite Ms. Chanel Davis-Gentle to do an evaluation and vote of thanks for us. Be safe, everybody. Good night. Chanel?
Good night, everyone. So the evaluation link has been placed in the chat. Remember to do your evaluation so that you will be able to get your certificates. And it was placed more than once. You should try to do it within the week, and it will take some time to get these certificates. So you should give it at least 3 weeks to a month. And if you didn't get it, once you knew that you did your evaluation, you could email and let us know. So good evening, and I am Chanel Davis-Gentle. So all of CRMA, all the presenters, the moderators, we would like to say thank you. We'd like to say thank you by that prayer started us off. It was so powerful. We thank you, Ms. Cadogan. A heartfelt welcome was felt by the President's remarks, Ms. Curtis, Dr. Curtis. Dr. Hartman and Dr. Lan, we thank you for those opening remarks. Special thank you to the presentators for the SOMI reports. Dr. Hartman, Dr. Lan, Ms. Stewart. Ms. Pilgrim wasn't present, but her presentation was well done and recorded. Ms. Lewis and Ms. Campbell. We had some powerful words coming from that SOMI report, right? Life-saving investment, midwifery-led care. We'll also like to say a special thank you to the third set of presentations, Dr. Menz, Mr. Moore, and Mrs. Clark. Your presentation was well received. We say many thank you again to the moderators and all the members of the Education Committee. And leaving the sessions this evening, we have some words that stand out to us that came across from all the presenters. We like to remember them, starting with push. That was one word that was said many times. Strengths, support, quality, purpose, and God. So we started off with God and we ended with our last presenter. She spoke about God. So thank you again, everyone. Have a blessed evening, and we look forward to many, many more of the Education Committee hosting in CRMA. And we continue our AGM tomorrow. Please, God, we put you back on to Ms. Rolla.
Just to say thank you everyone for being part of today's proceedings, and we will meet again tomorrow when we will do the business of CRMA. It was an evening well spent, very, very, very informative. There were great presentations. I think the things coming out of the chat, all the presentations were great, excellent, very informative. So ladies, a job well done.
Thank you very much, Education Committee. Thank you very much for giving us, again, an excellent education night for our AGM.